Okay, I'll give it one more minute and then we can start. Okay, so anyone who just comes in, I'll just continue to add them to the chat, the meeting like before. So for the ones that are here, thank you so much for coming. Today we have Mrs. Ellie Edlmann, and she's a graduate of Brighton and Sussex Medical School and completed her medical training in the South Thames Deanery before transferring to the Southwest for her neurosurgical training. She currently is a lecturer in neurosurgery with a passion for advocacy and academia. And during this time, she also completed her PhD at Cambridge University in clinical neuroscience and worked on the national DEX-CSDH trial, which she recruited around 750 patients to a randomized study on dexamethasone versus placebo to treat chronic subdural hematomas, which we're very happy to say that she's here to speak about today. So without further ado, I hand it over to Mrs. Ellie Edlmann.
Thank you very much. Thank you for the introduction. I had almost forgotten where I went to medical school. It was so long ago. It's a pleasure to chat to you. I'm sorry it's hard to be interactive because online world, but I'm sure we're all used to it now. And apologies, I am at work, as you may be able to tell, so hopefully I won't get interrupted. But if you see some background people, just don't worry about that. So I'm going to talk about chronic subdural hematoma and dexamethasone. You may or may not have heard of the DEX-CSDH trial, which was published in the New England Journal at the end of last year after kind of 5 years of work. And I'm going to take a little bit of opportunity to talk about chronic subdural in general, only because it has become kind of my interest in general, and I spent my PhD doing lots of work in this area, so I always like an opportunity to talk about it. So I'm going to just, oh, I think someone's on, needs to mute. Thanks. So this is the paper, if you want to go and look it up. Prof. Hutchinson from Cambridge is the PI. And it was obviously a collaborative piece of work with lots of people from across the UK who contributed. And it was funded by the NIHR. And the SBNS and the BNTRC were kind of pivotal to making it happen. So it was very much trainee delivered. And I've been part of the BNTRC, which is kind of the trainees equivalent of NANSIG in terms of running and delivering studies. So why did we do this research question? Basically, chronic subdural evacuation is a really common operation that usually the junior neurosurgeons in the team do. In fact, it's probably one of the first things that you learn to do as junior neurosurgeon. And the incidence is rising, mostly because we have an aging population, also because of things like antiplatelets, anticoagulants being increasingly used for stroke prevention. And we wanted to have a trainee-led study, and the BNTRC, some of the trainees, I hasten to add, not myself, actually came up with the idea for this study and kind of put together the first workings of it. And then it grew into £1 million funded study. Chronic subdural is good because even though it's something that's been around, quote unquote, forever, and we do it a lot, actually there isn't that much research in the field. So there was a real lack of good evidence base in this area. So we thought we were onto a good thing. Just going to talk a little bit about what a chronic subdural is. I'm sure you've learned at medical school your layers of the meninges. So you've got your arachnoid layer at the bottom, and you've got your dura at the top, you've got your pia right at the bottom, obviously on the brain surface. But between your arachnoid and your dura, there is actually this magic layer of cells that lots of people don't actually necessarily know about or have heard of, called the dural border cell layer. And it's this cell layer that splits open, and this is where the subdurals form. And this cell layer is kind of a weak cell layer, it hasn't got much collagen, and that's why it's prone to separation. And chronic subdurals are classically only in the elderly or the older population. So it's unusual under the age of about 60. The mean age is about 70, 75. And that's because as you get older, your brain shrinks and it kind of pulls away from the skull surface, but the periosteal dura remains firmly adherent to the skull surface. So you get this kind of natural gapping that occurs, and it's the dural border cell layer that is the weakest, and that's where you get this opening. And so that's what you see your classic chronic subdural, which is this collection of blood and fluid overlying surface brain, and it kind of makes that crescent shape. And it's normally dark like that, so it's hypodense on a CT scan. And how does it actually form? So we know it's in that space. Well, when I was at medical school, I don't know if it's changed, but we were told that it was bridging veins that cause chronic subdural. It's not a complete fallacy, because if you tear a bridging vein, you'll get an acute subdural. And if you don't treat an acute subdural, some of those acute subdurals will become chronic subdurals over time. And I think the general belief was that all chronic subdurals were acute subdurals that had just never been diagnosed at the time. You know, it was missed trauma. No one saw the acute subdural, but it's now become a chronic subdural. There are a proportion of those that happen, but actually, interestingly, there's a much larger proportion of them that don't come from acute subdurals, but come from normal brain scans. So if you scan everybody when they have their acute trauma, which tends to happen now, because if you're old and you fall over and you bang your head, you pretty much get a CT scan within seconds, then we know that their scans can be normal. In fact, probably in about 2/3 of cases, they're normal. And even so, 2 or 3 months down the line, they develop their chronic subdural hematoma. So it isn't acute bleeding, and it isn't tearing of bridging veins in the vast majority of cases that cause chronic subdural hematoma. What it is inflammation. And I'm sure you'd love to read this paper, which goes into lengthy detail about it. But all you need to know is there's a lot of inflammatory markers. And what happens is probably, I'm sorry, this hasn't projected very well, but you probably get a trauma. Maybe you split open that dural cell layer a bit more than it has been, you know, particularly if you're older and you've already got a bit of an opening there. But there's some kind of injury that happens there, not necessarily acute bleeding though. And in fact, as I've said, in the majority, not acute bleeding. Then you get inflammation, you get all these cells drawn in. This inflammation starts trying to repair things, it starts making new membranes, but instead of just repairing the dural cell layer, it makes 2 new membranes, and these have their own fragile capillary network. And then you get these leaky vessels that are not properly formed, and that in turn starts to bleed within the space of the new membranes. So when you have a chronic subdural, it always has an outer and an inner membrane. It's kind of this little encapsulated collection. And then once it started, as with many inflammatory things, it goes on and on and on, and it's kind of a self-perpetuating thing. And so that is why, as an inflammatory condition, an anti-inflammatory like dexamethasone is theorized to work to dampen down that response and help you reabsorb your chronic subdural. So steroids started way back when, in the 70s, and they didn't understand this pathophysiology at the time. In fact, they didn't even have CT scans at the time, so they were diagnosing subdurals on scans like this, where you can just see the displacement of the blood vessels where the arrows are, and shows that there's a subdural collection. And in this study that was done in New York, actually in the 70s, they tried to just give people loads of steroids because they liked doing that in the 70s generally. But actually they found that 70% of patients could be managed conservatively, so they gave them steroids and they got better. And these days we pretty much manage 100% of patients surgically, so that's quite an impressive conservative rate. And so they said, look, we think this is a reasonable way to manage people. Nonetheless, it didn't really take on, and moving way forward back to up to 2005, the Dutch then really started using it, and some of the Europeans started using it. So they did this study, some patients who were given DEX who were not fit for surgery, and some patients who had surgery with DEX in addition. And the study wasn't really significant, small numbers, but what they did find is the recurrence rate in the patients who had DEX as well as surgery was much lower, 4%, than those who just had surgery. So if you gave people DEX as well as surgery, they seem to do even better. And we know that recurrent chronic subdurals, so those that come back even though you've operated on them, can be a problem. So steroids definitely seem to solve this problem. And again, they showed, if you can see these pictures, the subdurals on the left and completely gone within 4 weeks on the right. So they showed that you could give steroids and not even need to do surgery. So there was a reasonable amount of data to say that this worked. And this is the last one. This is a review on nearly 500 patients. And basically, again, it was their common practice to give steroids before doing an operation. And they found that the longer you gave steroids before the operation, the less likely this chronic subdural was to come back again. So they had a significantly lower recurrent rate, and they didn't find any problems with steroids. However, we know that steroids have been used successfully in these studies, conservative treatment and as an adjunct to reduce recurrence. But we also know that steroids in big studies like the CRASH study, when you give them in general head injury or spinal injury, have a lot of side effects and a lot of morbidity. So people started using steroids, it was creeping into practice, but actually no one really knew what the side effects of it were. So there's no level 1 evidence. even though practice was starting to change. The Centaria study 2009 in the Lancet showed that if you used a drain when you drained your chronic subdural, that significantly reduced the rate of recurrence. If you reduce recurrence, then you improved mortality rates as well. So we know recurrence is important. We know it improves survival and outcome. And at the time when we were designing the study, recurrence rates were still 10 to 15%, so pretty high. So what did we do? We kind of got together with the SBNS. We got over £1 million from the NIHR, which is always handy. And we kind of designed this trainee-led study. And the hypothesis was that dexamethasone compared to placebo could improve your 6-month functional outcome if you had a symptomatic chronic subdural hematoma. So not the tiny ones that don't need anything doing, but the ones that would normally come and be operated on. We think that that would work by reducing the surgical interventions and reducing the recurrence rate. So as I said, it was a placebo-controlled trial. We gave people a 2-week course of dexamethasone. They had to be admitted to a neurosurgical unit. There were a few exclusions, mostly in relation to the dexamethasone. And they had to start their medication within 72 hours. It didn't matter whether they had surgery or not. So they could be randomized to dexamethasone placebo and then either have surgery or not have surgery. As it happened, most patients still went on to have surgery through nature of the fact that steroids take some time to have effect, and most people land in a neurosurgical center and within 24, 48 hours end up going for surgery anyway. So it really became a surgical trial, even though you were allowed to be a conservatively managed chronic subdural within the trial. Our primary outcome was the modified ranking scale, which is a functional outcome. You can just see it here, normally used in stroke studies, but because this is kind of an elderly population and chronic subdurals kind of mimic stroke symptoms, it felt like an appropriate measure of functionality. We looked at a few other outcomes in terms of quality of life, obviously mortality, length of stay, adverse events, particularly those we'd expect to see with steroids. We did a health economic analysis. The stats plan, I mean, so we had a target of 750 patients, which might not sound like a lot, but it's a lot to recruit to a trial, because you only ever really, of all the patients you screen, you maybe be lucky to recruit 20% of them. So it was planned over 3 years, and we thought that the assumption was that steroids would improve the favourable outcome, so a higher rate of MRS 0 to 3, improving it from sort of 80 to 85% to 88 to 93%. And it was done on an intention to treat analysis, but we did do some secondary analysis per protocol. So this was the recruitment. As you can see, most of the units across the UK recruited patients, some more than others. Obviously, as Cambridge was the lead site, we recruited the most. The green line was the planned trajectory. The orange line is the one that we took, which only took 6 months longer, which is not bad for a trial. Lots of trials overrun by many years. So we took that. So you can see how many patients we screened, and then obviously we randomized 750. 2 of them actually then got immediately excluded because they'd essentially been randomized in error. They were ineligible patients, but the rest of the patients were assigned appropriately to the 2 groups. And you can see the loss to follow-up was actually pretty low, 20 odd in each group. And we had more data at 6 months than 3 months, because some people missed their 3-month follow-up, but then came back for their 6-month follow-up. So we had pretty good numbers of patients at final follow-up. We had less than 15% loss to follow-up, which is acceptable. And these are the results. So you can see the dexamethasone group on the left, the placebo group on the right. Essentially, all the baseline characteristics, the age, the gender, the symptoms of presentation, particularly their MRS score on admission, so how independent they were when they came in, were equal between the groups. So the groups were comparable, which is exactly the point in a randomized study and is what you would expect. And most patients, 60%, were MRS 1 to 3, so were pretty independent before they came in, and 94% only had a GCS 13 to 15, which again is what we know. Chronic subdural kind of mildly affects your cognition and your functionality, but it's not normally patients severely in coma. We know that 70% of patients report head trauma. Nearly half of patients are on some kind of antithrombotic medication. We know again that that's higher in chronic subdural patients. Some of the patients had chronic subdurals on both sides, and all of the imaging findings were comparable again between the groups. So we looked at things like midline shift, which obviously are predictors of outcome, to make sure that they were the same. And as you can see, 94.2% had surgical evacuation of their chronic subdural. So as I said, most patients ended up having surgery plus dexamethasone or placebo, as opposed to just conservative management with dexamethasone or placebo. Most patients had burr holes, most patients had drains. this is kind of the take-home outcomes. And these are the MRS scores, and the good MRS scores, so 0 to 3, is all the light blue things, and the bad outcomes, the bad MRS scores, are the yellow, orange, and red is being dead. And so you can see from discharge to 3 months to 6 months. At discharge, the groups are about the same. So by discharge, whether or not you had dexamethasone or placebo, you were pretty much the same. By 3 months, you can see that there's a big difference between the two groups. And by 6 months, again, there's still a big difference. And what we found was the opposite to what we had kind of sought to find, which is that the patients who we gave dexamethasone to did much worse than the patients who had placebo. So patients with placebo, 90% of them did well, and in the dexamethasone group, only 84% of them did well. So placebo is better than dexamethasone, which is the point of the trial, to understand, what's happening. But everyone thought dexamethasone was great and was going to stop people from needing operations. We did some adjustments for age and GCS and things like that, and the outcomes were the same. Again, the odds of a favourable outcome with dexamethasone were lower. Per protocol analysis was the same. So all of the stats were very convincing that dexamethasone is harmful to patients. And the question is why? It's not that surprising when you look into it a bit further. So the mortality at 30 days was much higher in the dexamethasone group. Mortality at 6 months was much higher in the dexamethasone group. Interestingly, the repeat surgery for recurrence was much lower in the dexamethasone group. So all of the literature that showed that dexamethasone reduced recurrence is absolutely spot on. It does reduce recurrence. It probably dampens down inflammation that's driving the cycle of chronic subdural and stops it from coming back again. Unfortunately, the harmful adverse events associated with dexamethasone counteract this. So even those patients didn't have recurrence and they didn't need further surgery, you can see from the serious adverse event rate, they had 16% of them had an adverse event within 30 days compared to 6.4% in the placebo group. And that's just the high side effect profile of dexamethasone. And AESIs were adverse events of special interest. So they were things we know that happen with dexamethasone, like high blood sugars, psychiatric symptoms, gastro symptoms. And unsurprisingly, again, they were much higher in the dexamethasone group. So these are the AESIs, the adverse events we knew happen. The endocrine disorders is diabetes, essentially. So dexamethasone can give you diabetes, which if you're old and frail is a really bad thing. Psychiatric disorders, so confusion, psychosis related to DEX, was much higher in the DEX group. And then these were all of the adverse events that were reported. But the thing that really stands out in the middle is the infections and infestations. And the infection rate, as you can see in the dexamethasone group, was much higher than in the placebo group. And again, by nature of the fact that it's an anti-inflammatory drug, it dampens down your immune response. That's great. It stops the chronic subdural cycle, but it also stops you from fighting off other infections. So the infection rate of 6.4% versus 1.1% is probably the critical thing in why dexamethasone was harming patients rather than helping patients. There was this small group of conservative patients, so those who'd never had surgery, only 6% of patients, so 38 patients. But even within this group of patients, those who had dexamethasone did worse than those who had placebo. So 16 patients had no treatment and placebo and did really well, all 100% of them. But of those that had no surgery, just had dexamethasone, only 82% of them did well. So we again harmed patients in that group essentially. So the outcome of the study among adults with symptomatic chronic subdural hematoma, most of whom underwent surgery, treatment with dexamethasone resulted in fewer favourable outcomes and more adverse events within 6 months, even though fewer repeat operations were done within this group. And the recommendation off the back of this trial is essentially dexamethasone should no longer be used with chronic subdural hematoma unless it's in a trial setting. I guess the only caveat is the dosing regime that we used was quite a high dose, even though it was only 2 weeks, it was still quite a high dose of dexamethasone. And so there's an argument to be made that if you could give a lower dose of dexamethasone, still with an anti-inflammatory effect, but not with the harmful side effects, because we know lower dose has a lower rate of adverse events, then perhaps you could have the good outcome of lower recurrence without all the harm. So there's scope for a study in that. I'm not sure I want to run another trial in that, but there is scope. So the other outcomes of the trial were that we found that surgery for chronic subdural actually has a very good safety profile. So 90% of patients in the placebo group had a favourable outcome. So, we can tell our patients, look, you've got a 90% chance of having a good outcome with a chronic subdural, which we kind of knew, but it's nice to have the facts and figures to be able to tell patients that. And 2/3 of patients got back to performing all of their usual duties. So about 1/3 of patients have a good outcome, but perhaps aren't as independent as they were when they first came in. Just some acknowledgements generally. Obviously, the NIHL funded the trial. Lots of patients and families took part in the trial, and lots of clinicians throughout the UK helped make the trial happen, which is really important. I'm happy to take any questions. I realized I managed to rattle through that quite quickly.
Oh, no, that was fine. Thank you so much. That made a lot more sense. And yeah, the conclusions really surprised me, but that's where I guess the importance of research and trials.
I think, yeah, I mean, the study basically totally epitomizes what randomized trials and research is about, which is that it was the complete opposite of what people expected. And everyone was like, why are you doing this study? Look at all the data we've got.
Yeah.
But it just goes to show, unless you do something in a controlled setting with clear outcomes, you don't really know the answer until you know.
Absolutely. Wow, thank you. So I've had some questions coming to me, and I see there's been some in the chat as well. So we only got like a couple minutes. So I'm going to try my best to maybe just like take one from each person.
Okay.
So I've got one question here. How important was the preparation of the study itself, the design, recruitment stats, and yeah, was there any things that you found more challenging in comparison to planning it to actually doing it?
So I would say study planning is like completely critical. It's obviously everything, because once you've started the study, it's very hard to make any changes. So planning your study from the beginning is the thing that takes the longest, and it was a couple of years in planning and designing the study, and it's the most important thing. And in hindsight, we could say, did we get the wrong dosing protocol? You know, should we have done a lower dose? And you can always go back and say, should we have done this? Should we have done that? But yeah, study design and having people who are experienced in trials in helping design your study is really important. Patient involvement is really important, because you need to know that you're going to be able to recruit patients at the end of the day. And again, one of the other things that we came across with was that the tablets were huge. They were like horse tranquilizers. And the first time I took them to a patient's bedside, he was like, yeah, I'm not taking those. So even simple things like that, you know, you need to know about the logistics of every aspect of your study before you go out there, and make sure you get it right so that patients want to take part. So yeah, and there are lots of things that you can make small tweaks as you go through, but you can't obviously make big changes to the trial design. So I would just say having experienced trialists helping you, if you want to design a trial or a study, having people with experience is the key thing, really. And Prof Hutchinson, who was the CI, has run several trials before this, so in that sense it was kind of smooth running because he knew what he was doing.
Oh, awesome. Thank you so much. I've got another question that's been put onto the general chat. First of all, they were saying thank you for the brilliant talk. And second of all, they're wondering if any other anti-inflammatory drugs were being tested for chronic subdural hematoma management, and why dexamethasone was used initially.
Yeah, it's a really good question. So dexamethasone was used because it's cheap and widely available, essentially. So steroids are, you know, great drugs because you can get them easily and cheaply. But yes, it would be better to have a more targeted anti-inflammatory drug. And the main, from the stuff that I did in my PhD, the main inflammatory marker that's a problem is VEGF, vascular endothelial growth factor, and you can get anti-VEGF treatments. They actually use them for a lot of ophthalmology things. They inject them into the eye. So if we could get an anti-VEGF treatment, which tends to have a low side effect profile, and use that, I think that would be ideal. Unfortunately, they're extremely expensive at the moment, so they're not the kind of thing, especially when the trouble we have is that surgery is so good. If you're saying you've got a treatment that has a good outcome of 90%, it's hard to convince NICE to fund a treatment that costs 10 times as much. But from a research perspective, I think it would be really interesting to look at that next.
Thank you. So I have another question here. Again, thanking you for the great presentation. They're wondering about the analysis done and the effects of dexamethasone alone versus placebo for patients who didn't undergo surgery. They're just like wondering what your thoughts were on the data that was collected.
I mean, it was such a small group of patients, it's really hard to say too much, other than the same direction of problem was found because those patients still had the bad side effects with dexamethasone. Having said that, if you've got patients who aren't fit for surgery and have no other choice of treatment, so they can't have an operation, essentially you'll die from a chronic subdural if you don't have treatment. So if dexamethasone works and you can't have an operation, I would say that's an extremely small cohort of patients, but there's a potential there for arguing for treatment in that group. There is another study, another trial that actually is going to come out soon called the DEXA trial, DEXCSDH, that the Scandi countries have done, and they looked specifically at conservative patients. So it'll be really interesting. I'm waiting to see what they come out with. That will really help guide whether you can get away with treating patients conservatively.
Oh, thank you. So I think final question from my understanding. This person again was thanking you for the talk, and they wanted to ask if there was any correlation in terms of outcomes with how long preoperatively the dexamethasone was taken.
We did look at time courses. The only thing that we found was that those that were more compliant with the DEX, so those that took the whole 14 days, had worse outcomes than those who were less compliant. Again, unsurprisingly, pretty much all of the patients didn't have much DEX preoperatively. So most patients had surgery kind of within the same 24-hour time window as starting the dexamethasone. So a lot of them had the treatments within the same time. So there wasn't really a big enough cohort to say separate out those who had a longer course preoperatively, because most patients had a maximum of 48 hours of DEX before they went to surgery. And that's because, as I said, a lot of patients, by the time they're in a neurosurgical unit, in a neurosurgical bed, they're there to have an operation. So even though they get recruited into a trial, which may or may not be dexamethasone, remember, surgeons don't know if their patients are on placebo, they tend to just get on and operate on them regardless. So we didn't really get that conservative cohort properly.
Okay, awesome. Well, thank you so much. We're just wondering if there's any other research areas that you would more likely to look into in the future.
Well, I'm still interested in chronic subdural, so I'm sticking on that, but I'm also looking at now, I've recently designed a study looking at antithrombotics in patients who have head injury. So when should we be restarting them? So a lot of patients come in, have a head injury, we stop their antiplatelets, anticoagulants, but when is it safe to restart them if they've got blood in the head? So that's my next interest.
Okay. Well, just wanted to thank you so much for the talk today. Really appreciate it. And I know for me anyway, I've definitely learned a lot. I'm hoping that's the same for everybody here. But yeah, a lot of people have just been sending messages saying thank you so much for the talk. And yeah, thank you so much. We really appreciate it today.
No problem. You're welcome. Thanks for having me.
No worries.
All right. Bye.
Bye.